arterial line. And it combines pulse contour analysis, or the analysis of your arterial waveform, and transpulmonary thermodilution as the calibration. It is able to give a lot of values like your cardiac output, cardiac index, stroke volume variation, pulse pressure variation, your global and diastolic volume, and extravascular lung water. And it has been shown to have good correlation with your PEC in patients undergoing CABG. For the flow track, the advantage is that you only need an arterial line, but you need a good arterial line waveform for this to give you good values. It has also been shown to have good correlation with your pulmonary artery catheter and is useful in major abdominal surgery patients undergoing the goal-directed therapy protocol. And one of the latest now combines pulse contour analysis and transpulmonary thermodilution, meaning there's a need to have an arterial line and a central venous catheter. Of the other monitors for cardiac output, we have the esophageal Doppler, which can give the cardiac output, cardiac index, and stroke volume. It uses a flexible probe with transducer at the tip, and the probe is the size of an OGT and can be placed for extended periods of time in intubated patients. However, there is a need to have a correction factor to compensate for aortic arch flow because it only measures flow in the descending thoracic aorta, which is approximately 70% of the total flow. Still, it is in good agreement with the pulmonary artery catheter derived values. And in goal-directed therapy, it has been shown to improve the stroke volume and cardiac output with faster recovery and shorter length of hospital stay. And lastly, TEE can give us idea of the cardiac structures, the filling status, and the cardiac contractility. The Doppler technique is used to measure the cardiac output, and it has been validated with the PAC with good limits of agreement. It is useful in hemodynamically unstable, mechanically ventilated patients. However, we need a skilled operator, and a standard probe cannot be kept in the patient for too long. The optimization of our hemodynamic status is a key goal in our perioperative management of our patients. And as the perioperative care physicians, we need to possess the knowledge and skills to provide this care in a competent manner. Though advances in hemodynamic monitoring have been tremendous in the past 30 years, the key in maximizing these monitoring modalities remains the same. It is in knowing what each monitor actually measures, when to use a particular monitor, where we place the components of the system, how to operate the system, and ultimately in knowing why we actually need to do what we have been doing. Good afternoon, and again, welcome to ISURA 2019.